So Dr. Abhijeet is a prolific, high-skilled surgeon from Mumbai. He practices in Borivali as Soham Eye Center. He has a very keen interest in academics and research is always keen to learn, always keen to get the fanciest of equipments, has multiple, presentations in conferences abroad. And today, he's also went an extra length. One of our speakers had to back out for some this thing. So he'll be covering 2 talks. He'll tell us how to do proper biometries and also the surgical pearls for presbyopic IOLs. Dr. Abhijeet, thank you.
Thank you. So we are talking about pearls in biometry. Optical biometer now is an essential for all presbyopic IOLs, but immersion biometry still is an integral part of our practice, especially for the dense cataracts. Immersion is very accurate, but in the era of multifocal and multifocal torics, Higgies wants ACD and Holaday 2 or Barrett or Olsen, they need more ocular data, and the modern machines are capable of doing that. So how do we improve our outcomes? So these are a few acts of commissions and omission that we do very often during our OPD. And most of the times it's hurry on the from the optoms, or incorrect labeling of IOLs, or no IOL or incorrect IOL on the day of the surgery. Please don't do indentation biometry. Immersion would be a better option. You should look at the echos. Do not perform keratometry after touching the surface of the eye, or if the surface of the eye is dry. These are the other important things, like not checking the steeper axis before the incision, or altering the A constants as per the surgical results over a period of time, and especially transcription errors in the era of Barrett online toric calculators. How many of us check the lateral canthus level when we are doing an optical biometry? This is very important because a small head tilt can give rise to a wrong reading on the toric IOL front, and you would be marking them with taking the lateral canthus into account, and you will end up with the error of placement of the IOL. The recommended IOL formula, there are plenty. So we used to follow the axial length criteria for such a long time, but over a period, Barrett or Hill RBF is very good, and it covers most of the axial lengths. And in post-refractive surgery also, Barrett True-K or the True-K toric works very well. We have newer machines which calculate the posterior corneal curvature and give you the actual total K, and even that works well in the post-refractive surgery. You have plenty of online formulas like the Barrett entire suite. You have the ASCRS multiple formulas wherein you can calculate on different platforms and then decide which lens you want to use. Dry eye treatment is very important, because if you see, this is a patient who was on the left hand side is without the dry eye treatment, showing an IOL power of 21. On the right hand side, it's showing a IOL power of 20 once the TBUT had improved. You need to validate your machines and calibrate your machines and validate your readings. So the most important part of validation is to remove the outliers of your readings. And here you need to go into the standard deviation drop-down menu of your biometer and go into certain details and find out those flags and remove it and get down to a minimum standard deviation. There are plenty of such things, and each biometer would have different validation criteria, and you should actually avoid outliers by whenever you are transferring data from the A-scan to the biometry, or from the biometry to the online calculators, double check those readings. Again, the head tilt, as I said, is an important cause of a wrong steep axis. Posterior staphyloma's optical biometer definitely works better, and it's preferable to use at least 2 machines for the K-metry to compare your Ks and see to it that they are accurate. As I said, remove bad images from the biometer. IOL master would have different ways of validation criteria, like you would have these exclamation marks against certain readings. You need to check those out in your drop-down menus. You need to refine your axis to a standard deviation of less than 3.5 degrees by choosing the right readings which are closer to each other. Look at the pupil barycenter, especially in presbyopic correcting IOLs. It's indicative of outlier. So if the dx plus dy, that's the distance from the center of the pupil to the visual axis, it will give you as a dx plus dy. If it is more than 0.6, preferably not to be used, these patients are not to be advised presbyopic IOLs. Angle, kappa, alpha, all these things are available, but as basic general ophthalmologist, we do not have fancy equipment to calculate those. So it's a good thing to center the IOL between the two Purkinje images, the first and the second, and that should usually help you. Higher in hyperopes compared to myopes, so be careful in these high hypermetropes whenever you are treating. So here's an example of biometry wherein we have an incision at 180, which is the normal thing we take, and it's showing a T2 model. But a simple change in the incision at the steep meridian is changing your model from a T2 to a simple plain IOL. So here is an example in which you would have different IOLs there, and in which IOL are you going to choose which particular refractive error or the spherical equivalent. So traditionally trifocals try to go either exactly emetrope or slightly hyperope. So the closest hyperopic to emetrope or emetrope is what you would aim at. While in EDOFs it would be different, in a lens like Vivity it would be different, like in a lens like Synergy it would be different. So go by the recommended criteria by the company initially, and then later on try to refine your outcomes. Now here is a patient who has a right eye toric and a left eye non-toric. So here you need to find out which instrument was used for taking the K-metry readings. So here unfortunately one eye was fed with the auto-ref K readings and the other eye was fed with the optical biometry readings because the patient was uncooperative and he had not, the optom had not told us. So these are the outliers which you need to find out. High hypermetropes or high myopes, you need to use different formula and then see which formulas are coming closer by. Like here example, we are using the Barrett or the Hagees or the Hill RBF, Hoffer-Q and the Holaday. So you need to decide which in your hands is giving you a better option after deciding your outcomes. Difference in topography readings is very important. Like the same patient is giving me two different IOLs at two different settings because he has come after around 6 months. And when we did the topography, it's showing a frank keratoconus in both the eyes. To summarize, optical biometry is important with newer formulae, premium IOLs but not indispensable. Please use immersion. Doing biometry before IOP or dilatation or touching the ocular surface is extremely important. Analyze your biometries over a period of time. You would set in a protocol for yourself and that is going to really help you in the long run. Please take the flags seriously. Head tilt is to be eliminated during biometry, keratometry or during toric marking. That will also help you increase the outcomes, improve the outcomes of the toric IOLs. Thank you. This is just an example, this is just an example of the Varion in which we usually go by the spherical equivalent, but actually the spherical equivalent, if you see the green, right hand side green box, is divided into the cross cylinder, and this is very important when you are analyzing and deciding which IOL to put in these kind of patients. Thank you.